Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to be spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors, Ketan Patel, Joshua Balfour, and Clay Smith. Okay, let's get straight into the first article, which was titled Pearls and Pitfalls for the Emergency Clinician, Beta Blocker and Calcium Channel Blocker Toxicity, out of the Journal of Emergency Medicine. So, among the top 10 causes of toxicological deaths, overdoses are beta blockers and calcium channel blockers because these are really quite common medications to have around the household. A lot of people are on these things. As for beta blockers, propranolol is probably the most dangerous, which has a significant proportion of the deaths. So watch out particularly for propranolol. For calcium channel blockers, verapamil, diltiazem, and amlodipine, those are your top candidates, with amlodipine taking up a significant proportion of those. Okay, let's talk about toxicity and treatment. First, let's talk a little bit about differentiating the two. A lot of patients are going to be on similar medications, and you often don't know exactly what anybody took. Both of these, calcium channel blockers and beta blockers, are both going to drop your blood pressure and your heart rate. But beta blockers are going to have a lot more CNS symptoms. You can have delirium, altered mental status, seizures, even without bradycardia and hypotension. So sometimes that can be the case. Sometimes they can only or start with these CNS symptoms. Beta blockers also are more likely to decrease your blood glucose, whereas calcium channel blockers, if anything, are going to increase it, but these are not reliable findings per se. Though the degree of increased glucose with a calcium channel blockade is a marker of severity. As for some other stuff to watch out for, sotalol, one of your beta blockers, does more than cause bradycardia and hypotension. It can also cause QT prolongation. So keep an eye out for that if it's on the differential, because then hypocalcemia, hypomagnesemia are going to become a lot more important for its treatment, particularly if you're running into things like tosa de pointe. Additionally, propranolol, probably why it's one of the more deadly beta blockers, can also affect sodium channels, thus prolonging your QRS, although giving bicarb isn't obviously beneficial in this situation, but it's very much understudied. A lot of the research that we have on a lot of tox things comes from animal studies because they're very difficult studies to do to recruit patients for. So giving bicarb likely won't hurt. And, tox histories aren't very good. So if someone comes in with some kind of tox history and they have a wide QRS, sodium bicarb is going to be your best bet. Along those lines, for perhaps unexpected findings for calcium channel blockers is that amlodipine can initially cause tachycardia before progressing to bradycardia. This is likely the result of vasodilation initially, and then affecting those channels in your heart, those calcium channels in your heart, and causing bradycardia. Now, if your patient does present relatively early, then activated charcoal is going to be something that you should give for these patients if they're coming in within the first 1 to 2 hours, and of course they are cooperative. Moving on to more treatments, you should start with fluids, and atropine is something that's, both of these things are readily at hand, and they're a good thing to start with, though they're not likely to be sufficient. Giving calcium may improve the blood pressure, but its effect is often going to be short-lived. And this works for both beta blockers and calcium channel blockers. Though not necessarily with severe toxicities, you're going to see a drop-off in the effect of this. Giving 1 gram of 10% calcium chloride or 3 grams of calcium gluconate is reasonable over about 10 minutes. You can repeat this until your calcium is about 1.5 times the upper limit of normal. Now, if you look at the textbooks, then glucagon is the therapy of choice for beta blocker toxicities. And it's not that this isn't true, but glucagon's very expensive, and typically most hospitals only have a very limited supply. So you can certainly do a trial of this, but do it with anticipation that you're preparing for the next steps if you have glucagon on hand. Now you've got a bradycardic hypotensive patient. Of course, you're going to be thinking about vasopressors. Norepinephrine or epinephrine, very reasonable choices, but not likely to be as useful as high-dose insulin, which we'll talk about in a second. Other choices like dobutamine, isoproterenol, and methylene blue, they have scant evidence, but they're not crazy either. They may help. Now let's get back to that high-dose insulin. If you see that there is cardiac depression, then high-dose insulin is likely going to be indicated. How does this work, you might ask? Well, for the most part, your heart survives off of free fatty acids in the blood. That's how it gets the majority of its energy. However, in these circumstances where it's stressed like this and you give high-dose insulin, then you can kind of force it to take up a lot of both lactate and sugars and work off of that. And that's how you get this actually powerful inotropic effect with high-dose insulin. Now, try not to scare your nurses too much, but they're going to have to give huge doses of insulin here. You can start with a bolus of 1 unit per kg alongside dextrose at about 0.5 grams per kg. And then you can start an infusion of the same over an hour. You expect to see some kind of improvement over the next 15 to 60 minutes. Monitor glucose and potassium, of course. These are going to be important things. It's kind of like you've got a DKA patient. Same thing. Anybody on an insulin drip, you've got to watch out for the same stuff. Crazily, you can titrate up this insulin infusion up to 10 units per kg, which are insane doses of insulin, but you do what you got to do. And if all of this fails, then you can consider intralipids, but probably reach for ECMO first if ECMO is available to you. There is some thought that giving intralipids and then starting ECMO, you're going to clog up that circuit. It's not going to work very well, so probably don't do both. ECMO, likely the better bet here. Intralipid therapy, while it has been shown to be helpful for LAST, that is toxicity due to local anesthetics, there's not that much evidence for actually giving it for beta blockers or calcium channel blockers. Kind of a toxicological last-ditch effort in most circumstances. ECMO, on the other hand, pretty good candidate for that. Now, like I said, a lot of this data is not based off of human trials, but rather experiments in animals. However, if that's all we've got to go on, then that's simply all we've got to go on. And for the most part, the algorithm that I just laid out from this article is what you see in most places. And so I'm starting to think it's probably the best thing you can do, and it's probably pretty solid. I like this review. It was well done, of course, by our friend, Britt Long. So in his spoonful, we did a quick review of beta blocker and calcium channel blocker toxicity, as well as the treatment. Okay, let's skip straight over to the fifth article. Titled Clinical Features, CT Imaging Decisions and Yield by Age in Adults with Abdominal Pain in the Emergency Department, out of the Journal of Academic Emergency Medicine. This is a really interesting study. Age is a risk factor for pretty much everything, at least in adults. As more time passes, the more likely you are that something will go wrong. And the elderly show less signs of disease, less fevers, less abdominal tenderness, less of most things, but have more disease. So I like this study, and they state that not only is there more uncertainty in the elderly, but there is uncertainty about how much uncertainty there is. We're not sure how much we don't know when it comes to the more elderly patient. And this is very important because in the elderly, a complaint of abdominal pain can carry with it a mortality rate of somewhere between 5 and 10%. That's on the level of having a STEMI, which is why I pretty liberally get CT scans in elderly patients. The introduction also mentions a study where they just scanned every patient with the complaint of abdominal pain who was over the age of 75, and they found a lot of diagnoses that no one was even considering. So, liberal with CTs is quite normal in elderly patients. But are we scared enough by this presentation? Many of these patients are actually being under-triaged. We don't know how much we don't know when it comes to abdominal pain in the elderly. So this was a reanalysis of prospectively captured data looking at patients with abdominal pain presenting to the emergency department So we know what diagnoses they had, we know how often they got imaging, and we also have the index of suspicion for acute abdominal pathology as recorded by the physician at the time included in this data. So they divided the patients into 3 age categories, 18 to 39, 40 to 59, and then 60 and up. They had almost 12,000 visits to the emergency department, and only 20% of them-ish were greater than 60 years old, so we could have had more elderly patients here. All the same, though, elderly patients had more diffuse abdominal pain, they had less nausea, vomiting, more constipation, and fewer of these patients had abdominal tenderness. Interestingly, the rates of right lower quadrant pain decreased with age. Right upper quadrant pain were about stable, and there was more left lower quadrant abdominal pain with age. As for the suspicion of the doctors for acute abdominal pathologies, it was actually quite similar between age groups. However, there was a lot more CT scans ordered for more elderly patients. That is, for every 3 patients with abdominal tenderness, there was 2 CT scans ordered among patients 18 to 39 years old. There were 3 CT scans ordered for patients among 40 to 59 years old, and for patients over 60. So for every 3 patients with abdominal tenderness over the age of 60, there was 4 CT scans ordered. So there's a lot more scanning in these patients, despite the physicians reporting that they have very similar indices of suspicion for acute abdominal pathologies. And the yield was also better for the CT scans as you got older, despite there being more CT scans. So even though there was twice as many CT scans for elderly patients compared to the youngest group, still there was a higher yield despite the larger denominator. And so we're scanning more and we're finding more, which means that these are appropriate scans. The yield for the CT scans in the youngest group was 18%, 31% for the middle group, and then for those patients over 60 years old, the yield was 38%, which is enormous. Abdominal tenderness on exam lowered in sensitivity as your patients got older. Rebound tenderness, on the other hand, maintained a very good specificity. Okay, so in a spoonful, fear, the painful abdomen in the elderly. Much pathology can be hidden there. Okay, let's do a quick wrap up of everything we talked about. From the first article, we did a quick tox lesson on beta blocker and calcium channel blocker toxicities. And then from the 5th article, we may not be scared enough of elderly patients with abdominal pain. We scan more, but we don't seem to worry more. And we have a lot of findings on those CTs. If you were hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles that you missed? Well, we compared intranasal to intramuscular midazolam for seizing children. We talked about how to identify true seizures over PNES, and then we looked at the role of steroids in community-acquired pneumonia in pediatrics. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.